Hello, I'm David Redfern. I'm going to take you through use of the MICA SOLO guide. Here we have the instrument tray for the SOLO guide. On the right hand side, obviously the targeting guide itself. Top of the screen, you've got the cartridge connector which attaches to it. Middle of the screen, you've got the blue 4mm and gold 3mm screw guide wire sleeves and the appropriate guide wires on the left there. And then coming into view now, we've got the cartridges which come in central, medial and lateral trajectories, usually central or medial, and these obviously vary the angle of the guide wire when attached to the jig so that you can place your guide wire in the correct position or the ideal position. On the bottom left of the screen, you've also got the recontouring guide, so when you've placed your proximal screw and distal screw, you can work off the screwdriver to the proximal screw with this sleeve to do your recontouring. It just positions a drill hole which you then use with your burr. I like to keep the setup really simple, so whether it's a left or a right foot, this is my setup. I always sit on the patient's left, the nurse at the end of the table, the C-arm on the right side, and you can see whether it's left or right foot, I'll still be able to use the C-arm in the same fashion. First of all, the skin incisions, first for the osteotomy and then for the wire and screw insertion. So the osteotomy incision is made at the dorsomedial corner of the first metatarsal, at the base of the metatarsal flare, the proximal end of that. And then for the proximal incision for the guide wire entry, I've got my thumb over the first TMTJ, and the incision's about 1 centimetre or 1.5 centimetres back from that, as you see here, roughly a blade's length. And then use the straight elevator just to create that working space. We'll just pause for a minute just to explain that the proximal skin incision, it really matters where you place this. And if you get that a little bit out of correct alignment, it can skew the alignment guide and hence your guide wire alignment. So I would strongly suggest, unless you're very experienced with this solo guide, that you do not make the proximal incision at this point, but you leave that until you've got the solo guide in place, your cartridge selected, and then you can see exactly where to make that proximal incision. Then with the burr, we're going to check our entry position, dorsomedial corner, proximal end of the flare of the metatarsal, just where the flare begins. So you can see I've checked that, then I'll go in with the burr at the correct angle, thinking about all 3 planes. And before I go through the second cortex, I'll just make a second check, make sure the plane is correct. This is going to be the apex of the chevron, hence it's important. You can see me just adjusting the plane a little bit there. And then I'll go through the second cortex. Once I've gone through the second cortex, we don't need the fluoroscopy. We're going to do the rest by feel, and we make the dorsal limb first. And it's a combination of a little bit of rotation of the hand and some translation, all very gentle. I've speeded the video up here, so you can see a bit of a soaring motion there, and keeping my hand high on the plantar limb there, which makes sure the plantar limb's short. An optional stage, I like to use the curved osteotome. I put it across the osteotomy there, and then lever, as you see there, right hand pushing the head up and then levering with the left hand, and it just frees up the periosteum there, makes it easier to then translate with the jig. The jig is best inserted with the hook perpendicular to the metatarsal initially, so you insert through the osteotomy and rotate your hand round as you see there. Then you can attach the cartridge connector, which you can actually do first of all, and then introduce the whole thing as one. And you've got to check it's in the correct plane laterally. It is important you also snug down the hook on the proximal metatarsal, as you see in the top right hand corner there. So we just pause again for a second, and I would caution you against assembling the solo guide and the cartridge connector before attaching the same to the patient. Much better to do as I did in the video, which is connect the solo guide and then connect the cartridge connector. It becomes quite bulky if you connect the two beforehand, and you could risk damaging the proximal metatarsal. Now to insert a controlling wire into the first metatarsal head. With the hallux flexed at the IPJ, you can control and correct rotation. You can see me pulling the hallux into varus. You should slightly overcorrect this, because as you translate the osteotomy, you can lose a little bit of alignment otherwise. So that first metatarsal head wire goes in as demonstrated. Then you can add your displacement. And if you haven't overcorrected in terms of a little bit of varus, you can just find the head fragment can drift a little bit into valgus. Something you'll get used to, but very straightforward if you slightly overcorrect as you're inserting the wire. Now for the cartridge selection, and you can see I've selected the central cartridge here. It's different on both sides. You want the slotted hole, as shown here in the top right hand corner, facing the skin. So just another brief pause here. As we discussed right at the beginning, it's better and safer to make your proximal skin incision at this point. Once you've got your cartridge in place and you've put the guide wire sheath through that, you will clearly be able to see where to make your skin incision. And what that does is avoid your skin incision tethering or pushing your guide and influencing the alignment of your guide wire and hence screw positioning. There are medial, central and lateral cartridges altering the trajectory of the guide wire in the direction as the names suggest. We're able to check the expected wire trajectory using this system as you see here, and by rotating the foot you can align the wire with the wire guide in the cartridge, and you get this image on the C-arm as if it were passing through the guide, and by doing so you know it's in the correct alignment, and therefore what you're looking at is the real trajectory. Happy with it? Then of course you can insert the guide wire through the guide in the cartridge, controlling the position as you see here, and then advance it once you're happy that it's all okay on the fluoroscopy. There you have a correct position. Make sure you check in the lateral view as well. You'll see here I needed to back the wire out a little bit. It was just through the metatarsal head, so it's a very important view. The next step is to remove the cartridge so that you can measure, and then you can drive the wire through the foot so that you can clip it and you've got control should it break whilst you're drilling, and then of course insert the screw, and you can see I've speeded up the video here. Need to make sure the screw is properly inserted, and then when you're happy with it you can remove the guide wire, and we're ready to go about the same process for the distal fixation screw using the same cartridge and then the more distal hole, and either inserting a 3mm or 4mm MICA screw with the appropriate wire guide. Same process, you need to remove the cartridge in order to be able to measure, and then when you're happy with the length, drive the wire through the foot, clip it, drill. But we need to be careful we don't damage the skin with the chuck in this area as indicated. And once drilled, then insert the screw, and I like to dip that in saline, just eases its way through the skin portal. Now of course you can resect the first metatarsal prominence freehand, but here you can see I've re-engaged the guide wire and the screwdriver in the proximal screw, and then you can use this little guide included to create a drill hole through which you can insert the burr and make your resection. So you can see me holding it to the foot here, and then you can insert the 3mm or 4mm wire guide and the appropriate wire, and then drive that into the foot, into the metatarsal, and then check on the x-ray, remove the guide, drill over that as you see here, and what you've ended up with is a little drill hole through which you can then insert the burr, and it just sets you off on the right plane. And then you've just got to sweep dorsally and plantar. Now the dorsal limb should be more oblique so you don't leave a corner to cause them irritation in their footwear. And then you can see me remove the plantar limb of that. And you can just chamfer and polish, if you like, that surface until you end up with a nice flat contour. You can finish that off with the 3.1 wedge burr through the same portal, and you can also use the same portal to then remove the bunion prominence, although I prefer to do that through the osteotomy portal. So to remove the bunion prominence, I would then go in through the osteotomy portal here, and I go straight into the bone and work from inside out, and you can check that on the x-ray so you know the extent of your bunion resection, as opposed to starting from outside, damaging the tissue before you actually start resecting. So I prefer the inside out approach. And then finally we're on to the Aiken, and that's straightforward technique, don't need the jig for that. And when you're happy with your correction there, insert the guide wire and the appropriate HV screw after drilling. So there we have it, the key steps. All the way through we've checked AP and lateral views, and we're only moving on when we're happy with each step. Very important you don't carry errors through, but the jig really does make the whole operation much more controlled. It controls the osteotomy, controls displacement of that, and the screw positioning and fixation. Thanks very much.